Hi, my name is Kathy Sadler. I'm doing my case presentation on mesenteric artery ischemia. My patient name is Mrs. VR. She is a 66-year-old retired secretary, married 45 years, with 2 children and 2 grandchildren. On the evening of January 7, 2017, she came to the ER with complaints of abdominal pain, abdominal cramping, bloody diarrhea times 1 day, and also feeling that she was going to pass out. Physical exam showed that her blood pressure was 70 over 40, her pulse was 140, temperature was 102.1, respirations were 24. Her eyes, ears, nose, and throat showed pupils were reactive, pink conjuncture, dry oral mucosa. Her neck was supple. Cardiovascular showed new atrial fibrillation with ventricular rate. Her pulmonary showed mild bronchi with no rales or wheezing. Her abdomen was hypoactive, distended, guarding, and rebound. Her extremities showed no cyanosis, but she had some slight edema to the lower extremities and no tremors. Mrs. VR past medical history shows a habit of smoking 2 packs of cigarettes for the past 40 years. She also has known past medical history that includes diabetes, type 2 for the past 30 years, COPD, hypertension, hyperlipidemia, CHF by diagnostic dysfunction. Also, 10 years ago, she was diagnosed with lupus. Her mother died of breast cancer at 80, and her father still lives currently at 89. Her medication includes right now, prior to coming to the ER, was Toprol, Singulair, Prednisone, Lantus, Advair, Lipitor, Genevia, and hydrochlorothiazide. So, with the mesenteric artery, it's called a superior mesenteric artery, and this plies the intestines from the lower part of the duodenum to 2/3 of the transverse colon and part of the pancreas. Mesenteric artery ischemia may occur with cardiovascular disease from the aorta. Mesenteric artery can be one of the outcomes of atherosclerosis of the arteries. Atherosclerosis is a chronic and inflammatory disease characterized by thickening and hardening of the arterial walls. Plaques composed of lipids develop on the vessels and calcify over time. Development of these lesions cause vessel obstruction, platelet aggregation, and vasoconstriction. Acute or sudden increased blood flow to the colon is caused by a blood clot. Damage to the affected bowel may range from irreversible to ischemic to transmural infarction with necrosis and purification. The injury is complicated by the reactive vasospasm in the SMA region after initial occlusion. Arterial insufficiency causes tissue hypoxia, leading to initial bowel wall spasms. This leads to gut emptying by vomiting or diarrhea. Mucosal sloughing may cause bleeding into the intestinal tract. Physical manifestations of this disease process include pain is moderate to severe, diffused, non-localized, constant and sometimes colicky. Patient is unresponsive to opioids. Abdominal distension and GI bleeding and signs of sepsis. If the bowel becomes gangrenous, tachycardia, tachypnea, hypotension, fever, and altered mental status may occur. Risk factors for this disease process is over 60 years old, CHF, diabetes, hypotension, taking medications to cause constipation. Incidence of this disease process is increasing with the population of people growing older. The incidence of ischemic colitis is underestimated because of the often mild and transient nature of this disease process. Diagnostic and treatments of this disease is history, including usual bowel patterns, physical exams, blood chemistry, ABGs, CBC, CT of the abdomen, X-ray of the abdominal ultrasound, MRI, MRA, and an angiogram. Mrs. VR was diagnosed with changes in her mental status, signs of septic shock, abdominal pain, and was diagnosed with ischemic colitis. The CT scan showed bowel wall edema, enlargement of the SMV. Her CBC, INR, BNP were abnormal. Her WBCs were elevated. Her H&H was decreased. Her ABG showed metabolic acidosis. Mrs. VR received an angioplasty and an exploratory lab and underwent a subtotal colectomy with an ileostomy. Patient was placed on vancomycin 1 gram Q12 IV, heparin Q8 sub-Q, Dilaudid 0.5 milligrams Q4 IV for pain, finger 6 Q6 with sliding scale, Lantus at night. She also was placed on TPN for nutritional support. And 11 days later, a percutaneous feeding tube was placed for nutritional support. Referrals were made to medical nutrition therapy for the TPN, then switched to tube feeding with Cerna 1.2 at 60 with an auto water flush of 100 per hour and liquid multivitamins. Respiratory therapy was consulted to maintain her respiratory status on O2, 2 liters, to keep her O2 sats above 92%. Physical therapy and occupational therapy was referred for deconditioning, for lower strength and upper strength. The ostomy/wound care nurse was there to teach her about ostomy care, which she'll be going home long term with her ostomy. Discharge planning was for her to go to rehab to continue her occupational and physical therapy for conditioning and strengthening. My last encounter with Miss VR, where she was working with Diane, the physical therapist. The patient was walking 20 feet with a walker with O2 2 liters nasal cannula, and she was very thankful for getting stronger. My reflection on this of Mrs. VR was with great admiration. Through this whole process, she was optimistic and happy. She was high-spirited. Her attitude was great. She wanted to do everything to get better. Talking to Mrs. VR and talking to her about lifestyle changes, stop smoking, diabetes, changing her activity level. Her goal was to be healthy, to stop smoking, and to live longer to be with her family. I also made her aware of her risk factors, that she still has a lot going on, that she has to be careful. Sitting down and talking to her and educating her on this was amazing. She was very receptive. I think with her near-death experience that she decided that this was time to change her life and live a better, healthier life. And I realized that sitting down and taking a slow pace, talking to my patients has helped me, and hopefully it'll help other nurses understand that we need to take the time to really get to know our patients and find out what their needs are and to help them and educate them. This is the end of my case study presentation. Thank you.